Thank you, Ms. Way. Mr. Wright.
Hi there. My name is Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. Really appreciate the dialogue today. And one of the reasons why we think this topic is so important is because MediCAL is central to our healthcare system as a whole. It finances over $95 billion to our healthcare system on which we all rely. Only $17 billion is from the general fund, but that leverages additional dollars and federal dollars and other funds, including the MCO tax. And that's why we're very concerned about the expiration of the MCO tax, since it is a loss of $1 billion. Just to put that into some context about the massive consequences, the cuts in 2009 and 2010 put this in perspective. The provider rate cut that you've heard about the consequences of was less than $1 billion. The eliminating benefits like adult dental and 10 other benefits was about $150 million, and those have yet to be restored. So trying to find $1 billion to cut in the MediCAL program would be catastrophic. It would force options that legislators of both parties have repeatedly rejected, even during the depths of the recession. For this reason, Health Access strongly supports the continuation and reconfiguration of the MCO tax, an important element of funding the MediCAL program. We are committed to assuring, however, that beyond that we want to make sure that people in MediCAL, particularly those in MediCAL managed care, as has been mentioned, have similar access to care as those of us with commercial coverage. And that means that they have a right to get an appointment within a set number of days, as is the standards in the Knox-Keene law and the Department of Managed Health under the Department of Managed Health Care. Part of the answer is money, but also part of the answer is accountability. That last year, this legislature passed and the governor signed SB 964, which we sponsored, to require review of network adequacy and timely access, and to require Department of Managed Health Care to look separately at MediCAL managed care. We think this is an important step, and we should be getting that data this year as a start. This year's SB 127, the Assembly is currently looking at to require accurate and updated provider directories, again, specifically separating out MediCAL managed care. So recent studies cited in your analysis demonstrate the data that we have now and that reinforce what we have heard anecdotally over and over again, which is that MediCAL coverage is meaningful and vital, but consumers who rely on MediCAL have greater difficulty obtaining timely access than those who have commercial or employer coverage. These studies by the California Healthcare Foundation and other sources confirm what you've heard from other stakeholders. There's a significant problem with access, especially to specialists, both in fee-for-service MediCAL and in MediCAL managed care. This is why we need adequate rates to ensure that there are adequate networks, so consumers can get MediCAL when they need it, where they need it, and that's why we oppose rate cuts. That's why we support rate restorations. While additional resources is not the sole solution, to the extent that increased accountability and scrutiny finds problems with access, like those have been identified, we need the resources to fix those problems, whether for specialists, whether in rural areas, as was cited. And that's why we need more resources and not less, as threatened by the loss of the MCO tax. In addition to the MCO tax, we believe we should identify other long-term financing, such as a tobacco tax. A tobacco tax would have the dual benefit of both reducing smoking and the state having to pay for the treatment of smoking-related diseases, as well as providing a revenue source to restore rates and address the other long-standing gaps in access that have been revealed with greater accountability. Just in conclusion, MediCAL is the source of coverage for 12 million Californians, but more than that, it is a safety net for all of us who may one day find ourselves without income during a stretch. It's a core funding for most major health providers that we all rely on. It's a financing that no longer just impacts those covered in MediCAL, but the health system which we all rely. And so California has an urgent need not just to prevent a dramatic hole that would be destabilizing to the state budget and to health programs, but to make the needed investments to benefit our whole health system. Thank you.
Thank you to all of our panelists for your presentations. Members, any questions or comments? I have a question about the MCO tax. Do any of you have any particular views of what structure is most appropriate for the MCO tax? A flat structure, a tiered structure, or is you mostly just interested in making sure that we have an MCO tax that fills the hole?
speaking for health access, I think our focus is on getting an MCO tax, extending the dollars, as Mr. Levine said, that would draw down those federal funds, which are really crucial. I think that's a really important component of it. Another key component that I think that's important about the MCO tax is that, again, I think all players of the health system have a stake in contributing to the health system and its viability. And I think to the extent that the plans should be part of that. And also, the other thing that's good about the MCO tax is that as healthcare costs rise, as they tend to do, the MCO tax contribution and ability to continue to draw down federal dollars also rises with it. And so it has that added benefit effect for the long-term sustainability of the MediCAL program. We do not have a position on the specific structure. What we believe that is, to the extent that gets worked out in the negotiations, that's something that we're willing to look at. But I think the core piece is that it's just a critical part of how we currently fund the MediCAL program. And in fact, we need to do more, not less, with the investments that are needed.
Great. A second question for you. Is there any doubt in any of your minds that an access problem exists in the MediCAL program, and that increased MediCAL provider rates will help remedy that problem, if you think it exists?
Happy to start. I think that there is. I mean, I want to be clear. There are some who overstate the issue and say that MediCAL is not worth. It's not any better to be uninsured than have MediCAL coverage, and that's not, and that's clearly not the case. People who have MediCAL coverage are in a much better situation than people who are uninsured. There is clear research of that, but it's also clear with the studies that are referenced in in the committee's analysis and others, that there are significant differences between commercial coverage, employer-based coverage, and in MediCAL, especially with regard to specialists, especially with regard in rural areas, especially in a variety of other sectors, and it's pretty clear that rates are a part of it. I don't think, as we mentioned in our testimony, I think that needs to be also included with some additional oversight and accountability. Some of that this legislature has already put in place in the last year and is currently considering other pieces that we strongly support. And so I think that it will help that situation. But at the end of the day, it has to be coupled with resources to be able to address those problems, and that's why we need to not just prevent loss of dollars, but actually make the investments to restore and invest in a program that works for all Californians.
I think we need to drill down to specifics. We know the low rates fee-for-service providers are being paid, but we don't know how much managed care plans are paying their providers. And I don't know if we'll ever know this proprietary information, but I think it is appropriate that the department, both DMHC as well as DHCS, continue to monitor access and report data based on plans as well as the delegated models. It's important to distinguish between the different intricacies of fee-for-service, managed cares, as well as the different providers.
Just to add on, because I think, Linda and Anthony both made very good points about the structures. I think another problem that we have in assessing the appropriateness of what managed care plans are doing is that we are literally sitting on top of a sea change in the MediCAL program. 5 years ago, I think 50% of the program was in managed care, and today it's over 80%. And that's a really big change, along with the new beneficiaries in the program as a whole. So, one of the things that happens that we know about newly insured individuals is that if you haven't had insurance before ever or in a really long time, you may not know how, you're not health insurance literate. You may not know how to access care that may be available to you. You don't know to call the health plan. You know, and so I think it's going to take us a while before we understand where those access gaps are, because the tools that we've used in the past to assess, you know, whether people are getting care, where they fall short, frankly, in really looking into the MediCAL population. And so I think, you know, investments that we could make, like the ones contained in the 1115 waiver application to the federal government, of investing in our healthcare delivery system transformation, trying to bring more community health workers and navigators on board. Those sorts of healthcare workers will really help us to expand the capacity of the existing workforce, while we look at how to target the investments with the revenues we do have to get the most bang for our buck in terms of expanded access. So, you know, it's a complicated answer to a simple question, I think.
Thank you to all of our panelists, Ms. Cabrera, Ms. Way, Mr. Wright. Appreciate your input and comments today. We are next going to our final panel, our panel of one, a managed care organization tax, Nick Luizos, California Association of Health Plans.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans, or CAP. Thank you for the opportunity to be here, to be the one-man panel. Thank you very much. Just by way of background, Mr. Chair and members, CAP represents 46 Knox-Keene licensed health plans under the Department of Managed Health Care. Our members come in all shapes and sizes. Our health plans are public, not-for-profit, or private organizations, and they collectively provide health care to just about 28 million Californians, or about 95% of the healthcare coverage market in the state. More than half of our plans participate in the MediCAL Managed Care Program in one form or another, and our plans certainly value the partnership that we have with the Department of Healthcare Services. And we agree with the administration that finding a replacement for the existing MCO tax is an important priority. Today, our MediCAL plans pay the existing iteration of the MCO tax, that has been discussed already today. Because the existing MCO tax is limited to MediCAL plans, it does not raise taxes on individual or employer purchases of health care. CAP was a strong supporter of the current MCO tax when it was originally passed in 2009 for the purpose of saving the Healthy Families Program, which was an insurance-based program for children that enjoyed bipartisan support. Of course, we're here because several things have changed since then. Number one, the Healthy Families Program no longer exists, as it has since been folded into MediCAL, the state's entitlement program for lower-income Californians. And the MCO tax was, in essence, transferred to support the MediCAL program instead as a result of that elimination. Number two, and more relevant to this discussion, is that the federal government, as we know, has issued guidance suggesting that California's existing MCO tax does not meet federal parameters. Among other things, our MCO tax must be broadened to all health plans, not just the MediCAL plans. And this means that for the first time, individuals and employers paying health care coverage in the private markets are now being asked to pay the cost of an MCO tax if we enacted a new one that meets federal guidelines. And I just want to emphasize this last point is important because it embodies the reason that we're really here. We're not here because of anything the administration has done. We're not here because of anything the legislature has done. And we're certainly not here because of anything the health plans have done. We're here because for years the federal government matched with federal dollars the revenue that was generated by our existing MCO tax and thus deeming it compliant. And now it's changed its mind. And it wants all plans to pay the tax. Therefore, under this new federal construct, the MCO tax is now a health care coverage affordability issue for the first time. This is challenging, but despite this challenge of our new reality, Our trade association believes that California's existing MCO tax does provide important financial support to MediCAL. So we've made the decision to work constructively within our membership, with the administration, and with the legislature to find an alternative tax, if it exists, that can fill the hole in the MediCAL budget and garner broad-based health plan support. In December of 2014, our board, CAP's board of directors, created a work group of plan experts and consultants to determine whether a tax could be constructed that meets certain guiding principles. The principles that define our work are pretty straightforward. We believe that, among other things, any new tax must directly benefit the MediCAL program, be equitable to the payers of the tax, and consider affordability to the purchasers of health care coverage. We believe that if you're going to tax people who are doing the right thing and buying coverage, either for themselves or for their employees, that the money should go directly back into improving the healthcare system in California. Affordability is also important because millions of Californians receive coverage through their employer or purchase it on their own. Private purchasers of coverage today are already paying higher taxes due to the imposition of what's called the health insurance tax that was a part of the Affordable Care Act. In addition, large purchasers of health care coverage are facing what the excise tax, commonly referred to as the Cadillac tax, on higher benefit plans, if you will, which kicks in 2018. So that's on the horizon as a new tax for coverage. So, we feel that the health plans, purchasers, and policymakers have to be sensitive about adding new taxes to health insurance that will only make it more difficult for people to purchase health coverage. Taxes and fees already represent a pretty significant percentage of the premium dollar. But back to our work group and its efforts. Our work group organized and then exhausted the first part of 2015 analyzing the administration's January MCO tax proposal. Upon analysis, we recommended to the budget subcommittees of the houses to reject the administration's proposal. The proposed tax did not meet the principles that we laid out and therefore could not garner broad-based support within our trade association. And, I want to be sensitive to the difficulties of constructing a new MCO tax, and that's not a criticism of the administration. This is very hard work and very complicated work. In any case, soon afterwards, CAP, working with our partners at LHPC, or the Local Health Plans of California, began really at square one on developing a better understanding of what the federal Medicaid provider tax rules really say, and identifying areas of flexibility within those rules that might lead to a better result. We learned many interesting things. Number one, you don't have to tax managed care plans under these rules. There are a list of 19 classes of taxable entities that can be considered. Number two, you don't have to tax enrollment, and the administration's proposal was enrollment-based, but in other words, there are other units of measurement, if you will, that can be taxed, like revenue. And number three, that this is more than a policy or political exercise. It's really an exercise in math. And which has been challenging. And like I like to say, I was a poli-sci major for a reason. It was a math avoidance decision on my part. But in any case, in order to deviate from the uniformity rules of the federal tax guidance, you must pass a mathematical equation, or CMS will not approve any tiered structure, if you will, unless it passes a math test called the B1, B2 test, which is very complicated, so I'll save that for any questions. Using what we've learned, though, in really studying up on the federal rules, we started constructing and testing models. We looked at flat taxes, we looked at tiered taxes, we looked at an enrollment basis, we looked at revenue basis, primarily at first using publicly available data. In all, we initially modeled 21 different versions of an MCO tax, and each time we ran into the same issues. One model would achieve equitability, but was not affordable. Other tax constructs could be made slightly less expensive to the private markets, but at the expense of fairness in the structure of the tax, and lead to some sort of the same sort of market dysfunctions that were inherent in the administration's proposal in January. So, at this point, we do feel that it's time to get creative, and we're asking for more refined data directly from our member plans in order to test a new round of models that may better align with our adopted principles. At this point, we're currently in the middle of that process and project. I think the main point, or one of the main points that we want to leave the committee with, is that the task of creating an alternative MCO tax is made difficult by the constraints of the federal guidance, and a solution that meets our goals, regrettably, has yet to emerge from our efforts. But as I indicated, we are in the middle of a newer process. Fortunately, the federal government is allowing states to keep their current MCO tax structure in place until the end of their respective legislative sessions. This gives California all of 2015 and 2016 to find an alternative to the MCO tax that is equitable, supports MediCAL, and is affordable. In the meantime, the current MCO tax remains in place, generating revenue that does not expire until 2016. Now, having said that, that doesn't mean if a solution presents itself earlier than that we shouldn't take that opportunity. But we also shouldn't rush into a bad version of this tax that could be expensive for folks that have to pay for their health care. So, I'll leave it at that. I just want to close by saying that we're working, and this is very complicated business. We look forward to keep our connections with the administration, and we've had several positive conversations with them and this committee as our work moves forward. Thank you.
Thank you, Mr. Luisos. Any questions or comments from members? Mr. Thurmond.
Thank you, Mr. Chair. Thank you, Mr. Luisos. Could you just say a little bit more? At the end of your remarks, you were mentioning analysis of three different versions of what an MCO tax might look like, and you said that this one might have driven up prices, this one might have been unfair. Could you just say a little bit more about those three and just specify what those three are a little bit more explicitly, please?
Yeah, there's nothing inherently I don't want to say this. There's nothing inherently wrong with any construct of a tax, but they do contain certain tendencies, I guess. So you could do something that's a flat tax, which is something that's being proposed in the legislature. What we found in examining that structure is that there's a trade-off on affordability vis-a-vis the commercial markets. In order to raise the same amount of revenue, you would have to increase the amount or the burden of the tax on the commercial markets in order to achieve the same amount of revenue, is what we found in our analysis. And really, the reason for that is, one of the theories behind the administration's proposal, a tiered tax, was that if they created the tiers in a certain manner, I think what they were trying to do is to place all of the MediCAL plans in the highest tax tier, so that you could really leverage and maximize the federal dollars that you can obtain from CMS. And the MediCAL plans, because they're paid on an actuarial basis, see those costs reflected in the reimbursement rates from the state. So, having them here and, a particular commercial plan here is not necessarily a problem, but if you flatten the tax, you have to move the commercial plans up here. And so that means you have to raise more money from the private markets in order to raise the same amount of revenue. I think so that's a trade-off. And the trade-off with the tiered tax is, although you might want to try to leverage more federal dollars out of the Medicaid plans, just by basis of a plan's enrollment size, a problem that we saw with the administration's proposal is that we have a handful of mid-sized commercial plans that have absolutely no MediCAL business, but by virtue of their enrollment, they were placed in the highest tax tier. So that means, and they're competing in the same markets as these larger plans. So that is an inherent problem in that structure. So, is there a way to resolve those issues? We're trying. What I do want to emphasize again is that this isn't a political exercise, a mathematical exercise. You can vary from the federal rules, but you can only do so if you meet certain statistical tests. And if you don't, they will reject the tax. So that's an issue.
Thank you.
Yep.
Other questions or comments from members? A quick follow-up on one of the points you made. I think you made mention of other classes of providers that where revenue could potentially be generated.
Sure.
Has there been discussion about that? Are there any other areas where revenue could be generated that's politically palatable that could help assist this committee in generating the revenue that's necessary to replace what we're losing with the expiration of the existing MCO tax next year?
Yeah, so I mean, our work group efforts have been focused on what we can do in the managed care universe. But as you stated, there are 19 classes of providers or entities that could be taxed and have that tax revenue be matched by the federal government. Currently, California does 3 of them. We have the MCO tax, which is found non-compliant with federal rules. We do the hospital tax, and we do skilled nursing facilities. There are 16 other classes that could be considered. Those haven't been considered as a part of our work group as the trade association for the managed care plans and payers, if you will, at least a portion of our membership paying the current MCO tax. We thought the constructive avenue was to look at models that require the participation of our members, and obviously we can't compel the participation of other entities to participate in our work group. So at this point, our modeling is based on health plans. Yep.
No, I definitely appreciate that, and want to thank you for what you've been doing with your work group and your commitment. Obviously, been looking at all sorts of different possibilities and different types of modeling. I was just interested to see if maybe outside of the work group there was some cross-provider discussion, and sounds like that not really.
Well, we've I mean the only thing I can provide there, Mr. Chair, is that the hospital community obviously has a lot of experience on this issue, and we've been talking to them just to get insight on their experience, and there's definitely some shared war stories, but there are a lot of differences between our industries as well. So we have a unique set of problems and questions that we have to answer.